And we are, there it is. So I want to thank everyone for joining us today for the July 19th edition of our webinar. I'm going to quickly introduce our two speakers. First, we have Dr. Tom Talbot. Dr. Talbot is professor of medicine in the Division of Infectious Disease and the chief hospital epidemiologist at VUMC. Dr. Talbot has been at VUMC for over 20 years and was recently elected to serve in a leadership position with the Society for Healthcare Epidemiology of America. And then our second speaker who's going to be working with Dr. Talbot today is LaKita Buchanan. LaKita is a program manager here at VUMC in the hand hygiene program, which is housed in the VUMC's infection prevention team. And LaKita has been at VUMC since 2010, so over a decade. With that, I will go ahead and stop sharing my screen. And Dr. Talbot, are you going to be sharing your screen or is LaKita?
I'll share.
Perfect. You should have the ability to do so at this time.
Yeah.
Great. Thank you so much for being here.
Yeah, thanks everybody. I know LaKita's out there. I didn't see her face, but there she is. Thanks everyone for having us here. There's a nice wave from LaKita. You'll see her throughout the talk. Thank you for giving us a chance to come in and speak to you about maybe a topic that is kind of related to COVID and nursing homes, but it will be more related to kind of what you're doing, we hope, just kind of our experience around changing a behavior that's a kind of a reflexive behavior a lot of people do, and kind of walk you through that and hopefully have time to answer questions. So I'm going to kind of do the presentation, but LaKita has promised to jump in and raise her hand, and I may not be able to see in the chat, but we'll have plenty of time for questions at the end. So kind of want to dig in and kind of talk about what I call the hand hygiene adventure we've had at Vanderbilt. Let's see, here we go. Here's the disclosures for both LaKita, myself, and the rest of the planning program, as you see here. And I usually do acknowledgements at the end of all my talks, but for this project, I'm going to acknowledge everybody at the start, because this has been a really huge, massive team effort. And some people to call it in particular, Dr. Hickson, whose idea it was to do this program, Claudette Fergus, who you see in the middle down there in the picture. She was our lead program director, quality consultant at the start of the program, as well as Nancy Feistritzer, who was a chief nursing officer at Vanderbilt on the right there in the picture. And the picture I like because I look a lot younger, less gray hair, but it really illustrates that to do something like this, you really have to have kind of a collaboration with all the key stakeholder leaders that can really change practice. We've had a lot of good leverage with our data team, and we'll talk about some data management here as well. And do want to call out LaKita, who took over the program coordinator spot several years ago and really has continued to build the program into the success it is. And as you'll see, as I talk about the program, really thanking our observers, our leadership, and everybody at Vanderbilt, because this really has been a huge effort to change our culture and improve hand washing. So we'll kind of dive into what we did now. So I think it's important as we talk about hand washing, which when I was initially asked to run this back in 2008, I was kind of like, well, it's not really the most exciting topic, kind of boring. Seems like people should just know how to do the right thing. But we really began to realize that focusing on hand hygiene as a quality program really was important for multiple reasons. One is it's a safety practice, because if you wash your hands, you'll reduce infections in the patients we care for, in your all's case, the nursing home residents, in our own healthcare personnel. But it's also something that everybody does, no matter where you are on the totem pole, no matter who you are, you've got to do it. And it's where you can really create this culture of shared accountability amongst each other, amongst professionals. You can erode silos of practice where you say, that's not my thing, because it's everybody's thing. And really create that culture where not just for hand hygiene, but for other things, you encourage folks to really speak up and remind each other in a professional, collegial way, like we would want to be reminded to do the right thing. And that's really why Vanderbilt focused on this way back in the late 2008, 2009. So, 12, 13 years ago. And I go back to this picture. The gentleman up in the upper left with the bow tie is Ignaz Semmelweis. He was an obstetrician in Vienna in the mid 1800s. And at the hospital he worked at, they had two wards. They had a ward where the midwives delivered the babies on one day, and a ward where the physicians and training physicians admitted babies on the other day. So they would alternate admissions to the unit depending on the day. The problem is the mortality rate of the mothers was 3 times higher in the unit where the physicians and trainees were delivering than the midwives. In fact, it was so bad that the community knew that what day it was. And so if they were going into labor, they really tried to hold out to be in the day where they would be admitted to the midwife unit, because they knew that the other unit was not a good unit and people were going in there and dying there. And he began to use his epidemiology hat and start to look and notice that the trainees would be at the autopsy suite and then come in, deliver babies, and then go back to the autopsy suite to do their medical training, and began to connect and say, there is something that we are bringing in from that, because the people that are dying have the same thing that the women are catching. And I don't know what it is. This is before germ theory. And he had folks use this kind of really chlorinated lime solution you see there on the left, wash their hands. And really that was the advent of hand washing. And even then, though, that was, I only told you in the mid 1800s, we still have had a challenge with this practice, even in many hospitals up to today, on people doing the right thing and washing their hands. And there's various reasons to why people don't do it. They're often busy. And so it's really important. How do you get people to do this very basic, very fundamental practice that we don't teach in school because we assume you know how to do it, right? And so that's really kind of been the rub. So back in 2009 in the summer, this was our data. We were tracking it. We had 7 people that would go and watch people wash their hands. They had other roles and responsibilities. So you can see down at the bottom, we maybe would get about a couple hundred observations for the entire medical center a month. So not really enough to change practice, not really enough to be impressive other than to say we measure it. And you can see our compliance was pretty cruddy. We were sitting there around 50%. And for the 5.5 years before we amplified our program, we had a total of about 3,000 observations. So we really recognized for several reasons that this is something we needed to focus on. Now, part of the problem with hand hygiene practice and really training a behavior is that if you fail to wash your hands, you don't see the harm. For example, if we were to give someone a transfusion with the wrong blood type, you would very quickly see the harm in that. The patient would do very poorly very quickly. If you forget to wash your hands and have C. diff on your hands and spread it to a resident or a patient, they may not develop an infection at all. They may develop an infection down the road several weeks later. And so you don't connect that defect to that event. And so there's other reasons. You'll say, oh, well, they got C. diff because they're on antibiotics or they X or Y, and not because we forgot to wash our hands, because we never know for sure.
And you know what?
I think I got a couple of folks that need to, if you guys can mute your phone, or mute your speaker, that'd be great. Thank you. And it's hard to measure accurate hand washing. I mean, you basically have to watch people do it. And there's some, confounders with that. And I think even more importantly, it's something that's hard to remind each other to do. And I always liken it to, you got to dinner with your colleagues and you look at them and you say, hey, LaKita, don't forget to use your napkin. It can be really an insulting kind of way if you don't do it in the way we really intended as a reminder for each other. And it's really changing a reflexive behavior. So with that data, we really decided as an institution that this was not acceptable performance, and we really had to revamp the entire program. And we did a lot of different things to try and improve. And I'll talk about some of these in detail, but you see here on the slide a variety of things such as, how we're going to measure it. We increased how we observe, awareness of the data. We'll talk about awareness letters, making sure people had access to product marketing as well. And we really crafted this under a shared ownership program. And I'll talk more about that. So the first step was, how are we going to measure whether someone does it correctly? And there was a lot of discussion, more than I really wanted to do, about how do we really look at this? If we're going to do observations, what if someone walks in the room? What if they walk in the room and they don't touch anything or touch the patient? Should we really count that? And it became really complex to where you're like, we're going to have the observers shadow the people as they walk in a room and just look at what they do and then walk out and then decide whether it counts. And of course, that's not practical. And so we really finally settled on that really as you enter the environment and you exit the environment, we had to define what the environment was, what the patient environment was. That would be where we counted. This went all the way up to our medical center medical board for approval. And it was really important because you have a lot of people could chime in on how we measure, and then ultimately we'll have an agreement so that down the road we'd hopefully have less discussion about how we're counting. Because remember, we all talked about this and we really came to an agreement that this is important to measure. The perfect measurement is I hire another 14,000 people, then everybody has their own shadow and we just shadow everybody, but that's not going to happen. So how do we do this in a way that gives a snapshot of practice that we can improve upon, that we feel has, while may have some limitations, is a reliable measurement. And for folks that are in the know about how you measure, there are existing ways to measure. And the WHO, even before we started, had kind of what we call the 5 moments of hand hygiene when you go in to a patient. So before you touch the patient, before you do a procedure, after you have a body fluid exposure, after you touch the patient or touch the environment. And a lot of places will measure on all individual 5 moments, but that even itself is probably problematic. And if you think about what we landed on is you go in an environment and you leave an environment, you capture really moments 1, 4, and 5. And we had other ways to track whether you're doing hand hygiene for those other measures. So we made it very simple because as we talk about in a second, our model is going to rely on people to track performance. And we really need to make it efficient and simple for folks doing that. We had to get really in the weeds about what are the rules? How do you count? What do we do? What are the certain questions? I had a leader, a physician leader say, well, I'm going to walk in the room with supplies to change a dressing. And I put down my supplies and wash my hands. And now I pick them back up again. And oops, I'm contaminated again. I better put them down. I got to wash my hands again. And you want me to stand in front of this room and continue to just contaminate my hands and keep washing. I'll never get my work done during the day. And we're like, that's not really what we're doing here. And so we had to create rules like if you're carrying something in, then you don't count that. What if you're wheeling someone in a wheelchair? Well, you're with the patient environment, so you don't have to stop and wash your hands, but we do ask when you put the patient in the room, when you come out, you do wash your hands. We had to be that prescriptive so everybody understood the goal is not to get you. We don't want to play a game of gotcha. We want to have a reliable measure of practice that we all know is important to improve. We also have to be really explicit about what the expectations are. So, we want you to do hand hygiene. We want you to model that for everybody on your team. And we want you to make sure that you remind each other. And if they do it, say thank you. If you're reminded to wash your hands, your response should be, gosh, thanks, I forgot, and wash your hands and move on. And that's really the culture we're trying to engender. We had to make sure people had enough access to the products they needed. So we had to be really purposeful about how you had that, make sure that you had supplies, get more supplies available. Then the next thing we did was we actually changed how we actually collected the data. And we actually said, okay, all of our areas, you're going to have to identify someone who's an observer. And we're going to train them how to observe. And they can't observe their location because, I'm skeptical. And particularly as we talk about later, we had some financial carrots to this performance. You could be prone to just say everybody's doing it great and we're 100%, right? And so you'll go to this area, you'll do 20 observations a month. So not a lot. We want to be respectful of your time, but it also allows you to say, this is important enough that there's dedicated time every month that you go to observe and allows you to look at other practices, go back to your area. You may see things that you're like, gosh, maybe that's happening in my unit, I need to check on, and creates this interconnected responsibility and accountability amongst each other about providing data, but also really kind of the importance of the program. So everybody's into the pool, so to speak. Everybody's part of the game. And we had to make sure that we had some keys to how you observe. And I know LaKita will talk about this as we get to the Q&A. It was really important that you train them how to be an observer, that you had to make sure they understood how to do it. Now, we don't try to be secretive per se. People standing in a clinic, if you're not supposed to be there, usually they come up and ask you, why are you here? And you can say, I'm here to watch your hand hygiene practice. And so that's okay because we're trying to ingrain the right behaviors. We're trying to make it a priority. Every area needs to have observers and champions, and the more people that you train will become champions because our observers are only there for 20 observations a month, right? Maybe more now. We'll talk about some of the changes that we did. But we're not there all the time. We're not there at nights. We're not there on weekends. So really training everybody in the area to be comfortable how to speak up to each other and say, hey, don't forget to wash your hands, or I know you get your hands full. Do you need this? Is really important. We had to really train them on, if people push back, how to handle that as well, and make sure that, how to help, not just say we got you, but what are the steps for missed opportunities and how do you share that data and share that education as well. Now, we did have a benefit of, we have a financial carrot, so to speak, when we started this, is that we have malpractice insurance for all of our providers that we self-insure. So we have a trust. And obviously we do not want to have harms to our patients. We also don't want the trust to have to pay out. And so there were incentive programs before we started this about, if you do things that reduce the risk to our patients and reduce the risk of us having to pay out of the trust, we're going to give some money back to the departments, back to the front line. And so back in 2009, the Chief Quality Officer, Dr. Hickson, said, I want hand hygiene to be one of these metrics. And so it was one of the metrics associated with goals, and that if you attain the goals of performance, you will get a fairly good chunk of money back, and it could be fairly substantial. And the nice thing was that money would be spent on quality things like maybe quality advisors and other things. So we had that financial care that even if you said hand washing was silly, fine, but hey, there's a nice little financial carrot if you just get people to wash their hands. We had to be really transparent with performance and make sure people were aware. And so this is one of the early versions of our scorecards. And you see back in 2010, a couple key things to note is on this scorecard, it says this unit got no observations. And that puts accountability back on us saying, we didn't do a good job for you this month. We didn't make sure that you got some data to help drive your improvement. It'll break it down. We're able to tell in general terms, was it a nurse, a physician, or other personnel? What's your trend? But importantly, it also shows you in an identified way, it compares each other. And it's not to be like a tattletale, but just to say, if you're down at the bottom of this graph and your neighbor is at the top, then go down to your neighbor's unit and figure out what's working over there. What are they doing? That's really the spirit of improvement. We also tend to focus when we do these things on places that maybe aren't hitting our goals, but we really wanted to focus on places that really were. And so after a couple of years, we identified those areas in the various units and hospitals that were really knocking it out of the park, that they got it quickly, they had great hand hygiene scores, and they did phenomenal. We actually made them part of our next wave of marketing. So kind of, we did this and kind of help elevate those groups. And I want to highlight the woman in the bottom. She's also up in the upper right holding the canister of foam on that poster for the 6 South Cardiac Short Stay. And that was a unit that had done really well when we started. They really improved their hand hygiene and they sustained it. And we'd go up there and be like, gosh, you guys are getting it. What is happening in this area that we can take to other areas? And they said, oh, it's Edna. We're like, oh, Edna, who's Edna? Is she your nurse manager, your physician, medical director? Who's Edna? Edna was their ward clerk on that unit. And Edna happened to have a family member who had had a healthcare associated infection. And so she was very passionate about reminding people to wash their hands. And she was very respected in that unit. She treated others with respect. And so when it came from Edna, people really valued that. So just an example of how your champions don't have to be your leaders. They can be anybody. And so we really, it was a very fascinating snapshot of the culture of that unit and how they really could improve. Now, we would get pushback. Every little area or unit of their own group, and things like, and this was an email we actually got, I think, LaKita, we got this maybe like 2 or 3 years ago, so it still happens. Of, the email below with the data you sent me, but you know what? The nutrition members are visiting our unit for a few minutes, and why do we get in trouble? Because those people are not washing their hands, and they're not one of us, and we can't deal with this. And I think that's really also a cultural snapshot. We're all part of the same team, and we all can improve and leverage and change behavior. And so we really said, we have to change the culture so that, if you may not live in my county, but doesn't mean you can do any speed limit. You follow what we do in our county. And I make sure, and it's my professional obligation to be respectful for you as part of the team, that you are following what's our guidance and our rules for the county. So that was kind of the next phase. So you see what happened is we start doing more measurement. We improve our compliance. We're getting up to around 80%, which is pretty good. We're starting to get data in places outside of the hospital. So in clinics, in other areas. So a lot more observations. So you can give people enough data to drive improvement, which is really important, and see how they do. But as Dr. Hickson pointed out when we had this was, this is great, but it's still 1 out of 5 times somebody's not washing their hands. And that's problematic, right? We've got to continue to push forward. Now you can see where we went with this. So we were able to, and a couple actions we'll talk about in a second, really drive that compliance up to in the high 90s. And we've been really sustained there back and forth. You can kind of see the COVID dip there on the right around, at that way. And so we how do we kind of have to sustain that now 13 years into the program? Well, one of the big things was to make, the observers more of an active participant, and make sure that we remind people in real time. And then we also address when people have a pattern of just not meeting the goals that we all have mutually set together. And this, I will tell you that most of the time when people don't wash their hands, and I think LaKita can attest to this, It's not because of something like this. Now, this was a paper that was published in a medical journal by an OBGYN in England. It's striking to me. They're basically saying, I don't wash my hands between every patient because A, I don't see the evidence that shows it reduces infections. And B, if I had to do that, do you know how much time it would take me 1 to 2 hours a day to wash my hands? And that's just ridiculous. How can I possibly do it? That is a very rare opinion what we found. Most often people are just busy or they forget or they just haven't really focused on it and made it really a priority for their group. And I think that's part of the system that we work on a lot of our quality things is that you have to design a system to meet the goals you want and also have accountability in a professional way to meet those. And it's a balance beam to how heavily you weight that. Some things you really got to have a really structured system to make sure you do the right thing and less accountability. And other things with behavioral things, you've got to kind of weight a little more heavily on the right. And everything's a little bit different. And this is kind of one of Dr. Hickson's kind of models for how we really move to improve. And by doing that, you've got to have other key things within your process. So if your goal is to improve hand hygiene or your goal is to improve, safe care, whatever it is, you've got to have committed people, you have champions and the teams that will implement it. You've got to have a clear process that everybody values. If people said, we don't think hand hygiene is important, actually, this wouldn't have happened. You've got to have resources, you've got to have, and we'll talk about how you intervene, and you've got to have data to feedback and training and a lot of things like LaKita does and her team on how to do it safely and properly in real time. So what we then did was, as we're sitting about 80%, we definitely had units that were doing well, but we also had opportunity to improve as we followed this model of accountability. This model of accountability was really based off Dr. Hickson's work with physicians who would receive patient complaints. And what they found was that most physicians don't get any complaints. A few get kind of one-off complaints, but a small proportion of physicians get a large number of complaints. And those are often the ones that have dissatisfaction in their patients, may have harm, may result in lawsuits. And so he developed this pyramid of how you feedback. And if you feed back to individuals in a professional way to make them aware, 80% of people will change and they'll improve their complaints. It's really striking. Now, some complaints are very egregious. Like if you hit a patient, hit a resident in a nursing home, you don't wait for a pattern of that. That's got to be addressed to the top of the pyramid. But in general, those kind of complaints, you can feed back the data and people will improve. And if they don't, you've got to elevate that up and have commitment to elevate that response. So we took this model and we applied it to hand washing. And what we did was on the individual level, we trained our observers on how to remind each other in real time, have what we call like a cup of coffee conversation. That if I'm really busy and I forget to do hand hygiene, gosh, I'd want someone like LaKita to be like, hey, Dr. Talbot, don't forget to wash your hands. I know you're busy, or reinforce positive behavior, kind of do that. Now, if I yell at LaKita, if I'm non-credo, then that's something that falls in that red triangle that's not really part of a culture of safety, and that would be dealt with differently. But then also we looked at units and we looked at clinics and we said, where are the areas that are having a pattern? So we've been working with them and their performance is really below where other areas are, and how can we help with that? And so we created this model of first feedback and make people aware of where they sit and I'll show you what that looks like. And after a period of time, after we've been feeding back and working with the team, if things aren't improving, we then elevate that up and say, hey, we know you're committed to this and we know you're working on this, but what's going on? What barriers do you need? And then if you're still not improving, then maybe we need to kind of have more of a rigorous kind of action plan, which I will tell you, we've never gotten to a level 3 in all the years we've done this. We've gotten to level 2, but never gotten to level 3. And this is what it looks like. We send these out every month. They're a little busy, but they talk about how we're all committed to preventing hand hygiene. We all have agreed on these goals. And I want to make you aware because your unit is actually performing below these goals. And so you can see on the left is the letter we send when you start. And so you can see kind of the graph of the monthly performance and the year-to-date performance and how they start to drop. And we want to make them aware when it becomes a pattern. And then you kind of see, that we will continue to feed back to you as well. And then over time, as people improve, like the letter on the left, on the right, you see that steady improvement, and we will release them from awareness. So you've done really great, look at that improvement, continue it up, we'll continue to monitor, but we don't need to give you that awareness. We take you off that level. And that's something that we continue to do to this day. As you can see here, the impact of the program has been pretty massive. So you can see at the top, the compliance by year, a little bit of a dip down with COVID, but still in the high 90s. And the number of observations across the medical center, pretty substantial. We did start to see some drop off even before COVID, but definitely impacted with COVID. But then in fiscal year 22, and I'll talk about how we got to that, we had a record year for the number of observations that we've collected to feedback and drive data. I think there's some key lessons that we can kind of unpack, and I know LaKita has a lot of thoughts on these in the Q&A. But what I've found is that we have some really smart people that often will create reasons as to why compliance is low. Some of my favorite are, we don't need to wash our hands because if our patient, we're a preventive medicine clinic, so everyone's going to be healthy, and so if they're sick with stuff, they're not going to come into clinic. Well, we know that's not true. We know people go places when they have illness, as we saw with COVID. We know you can have a contagious infection and not know that you can be able to spread to other people, like MRSA or C. diff. And so that's one. I had someone tell me that, I think the problem is we keep touching the foam canisters, and we're spreading MRSA on the end of the foam canister. It's all contaminated. And I was like, well, if you're washing your hands, doesn't matter if you're getting MRSA off the end of that dispenser, you're killing it. That's great. You see that same rationale we saw in that paper I alluded to is I'm so busy, how can I possibly do it? And then kind of the deflection of, why are we focusing on our own staff? Why not the patients or our visitors? They're out touching everything out there, like the doorknobs at Walmart. Who knows what's on their hands? And I think that's just a deflection. We can remind those folks that we can definitely do more things on the part that we contribute. And so I think we see that as well. I think you really got to tackle minor issues that may become major. So things that would be like a little annoyance, you're like, oh, come on. And I think I'll talk about one in a second, but it can really balloon if you don't address it. I think you have to look in all your different areas where you have people working in the nursing home, in the healthcare system. What's the workflow? How are they able to get access to product? What are the practice areas like? And see how you can really help them improve compliance and actually measure it accurately. And know what swords you're going to fall on, what really things you say are absolute. And I'll talk about one that we really felt strongly about. And I think it's always important to have face-to-face discussions. And even often what we would do is, if we had skeptics, we would say, we'd love to get your feedback. Why don't we take 15 or 20 minutes and we'll go round on your unit and just see, let me see what you're seeing. And invariably, they would start to see, oh my gosh, these people are not trying to ding us. And actually, we aren't very good at washing our hands. So it's really striking as well. We'll talk about specific barriers. I think these are some from LaKita and her team that are really helpful, as you can see. So you got to make sure that people have stuff to do what they need, and they're in places where they would work. And I remember when we started, we would say, every doorway has to have one on the entry, and it has to be right at the doorway threshold. You can't put it 4 feet over there because it's not a natural reaction to reach over here to go get the product. It's got to be right there as I walk in, I use it. It's got to be within the flow of work. And we were really persistent about it. And make sure there's a process. If things are broken, who replaces those? Where are the supplies kept? Make sure that everyone knows, maybe that we all have a responsibility to note that. If people are going in and out, in and out, and in and out of an area, how do you really look at the workflow, make it so they can safely wash their hands without being like, oh my gosh, we would have instances where we have a computer where folks would enter notes and they would put it at the doorway to the room, like on patients, and enter in the data. And they're worried as they cross back outside the room with their hands, do I have to wash my hands as I move in and out? We're like, no, we're not going to ding you for that. Let's be practical about it. You've got to monitor for folks that have reaction, because as you start to wash your hands more, people are going to have irritation. In the wintertime, they're going to have dry skin. You got to have lotions. You got to make sure folks do things. If people wear gloves, make sure that they know they got to change their gloves and make sure they wash hands if they take their gloves off, because they can contaminate the glove box as well. How you handle as they walk in and out of the room, and how you can help folks. Often, again, most people are just distracted. There's very few instances where people are like, I think this is stupid, I'm not going to do it. And so we can talk more of that in our Q&A as well. I think as we found, as we impacted the culture unit by unit, you started to see that it wasn't just hand washing, and people began to have that collaboration and shared accountability and lower tolerance of what I call bad behavior. And people will be more willing to remind each other about unsafe practices, not just hand washing, in a collaborative way. And we have, occasional clinics now. There's one we've been dealing with recently that you can tell that the culture is kind of sick, and that they're very, the groups within the unit are kind of blaming each other. They don't work well together, and it's being reflected in how they respond to the data and how we work with them. So it's a larger thing than just the hand washing. I alluded to this earlier, but this was one thing, this was a sword that we really have fallen on pretty, that we really will not take your name. If we see people not washing their hands, unless you act inappropriately or unprofessionally. We will do that. And part of the issue is we'd have groups or areas say, if only I knew the people that weren't washing their hands, I could reach out to them. Or we even had places that said, I want to post the names of the people not washing their hands on a wall in my unit. So everybody, let's shame them. And we really said, that's not in the spirit of a just culture. We're only doing 20 observations a month. And so if you're at 60%, that's maybe 3 people. And if you're at 60% every month, it's not the same 3 people that are getting seen. It's probably more reflective of a larger issue as far as hand hygiene on your unit. And are we really measuring everybody all the time? And so really, that's something we've been really held firm on, that we really, in fact, we're having a meeting, I think, tomorrow or later this week about maybe taking names in an area. And I'm going to have the same perspective on that. I just think it's not the way to improve hand hygiene. We also would have folks say, show me this actually works. Show me that we're actually making an impact. We have a lot of people watching me and makes me feel bad about my practice, and it's a lot of resources that really improve outcomes. And so this was one of those things where I talked about a minor issue can become major, because my initial response to this was, at the time, my kindergartner, she's now a sophomore in high school, but my kindergartner, she knows if you wash your hands, you reduce infections. And I was kind of flip about it. But that would persist from folks. There were people that really want to know, is it making a difference? And so then I would pull out the WHO table that highlights here in gray all these studies that showed a significant reduction in infection rates with hand hygiene. And a lot of people would like that, but some would be like, no, I don't believe it. So we finally had to actually have our own data. And this is a busy slide where we looked at across our medical center. Each dot represents a month and represents an infection, a healthcare associated infection ratio. So the higher that is on the y-axis, the worse you are. You really want to be below 1 for that ratio. And you see a lot of months we're up in the 2s. And then on the x-axis is the hand hygiene compliance. And so you can see we found that as our hand hygiene compliance went up for the medical center, that infection rates dropped significantly. Now, there are a lot of things we were doing to reduce infections, but this also helped sway folks, help convince folks, oh, well, our data show it's reducing infections, so great. And so that was another way to help convince folks. It also saved a lot of money. And so this was an analysis of the first 3 years of the program that looked at our infection rates, looked at the cost of infection rates based on our own internal data, and as well as published data, and said, if we continued with infection rates as they were and did not reduce them, of which we felt hand hygiene was in part, not entire, this is the amount of money we would have, the cost of the infection, and would have been a cost to the health system, to patients, to length of stay and other things. So it's imperfect, but it does help, say when people say, gosh, having people observe is a lot of money. So is a lot of people that have harm from infections. One of the things we have most recently, which I think LaKita can really go into because it's really been a great benefit as well, is that we're part of a group called the Leapfrog Group, and that's a group of businesses that pay for healthcare, and they really have a lot of expectations for quality of practice, and they will rank healthcare systems on how well you do with a variety of quality. And really, it's very important. We really find it a very important thing for us to be ranked very highly. Last year, they began to amplify expectations for hand hygiene and saying, you need to make sure that anybody that comes to work in your area, not that just that you train them in hand hygiene, but they have to show you that they know how to wash their hands. So talk about an awkward conversation when you're like, hey, I know you're 30 years old, 40 years old, have a career. I need to see you wash your hands. And not only with the sink, but also with this alcohol foam. But we have to do that. And we do it in a way that really helps us prioritize the program. And we acknowledge that it seems strange to have to make sure we know how to wash our hands. With that, we hired new program managers. And you see Trinita and Ashley there. They're really our key kind of program managers. And they do more observations for us. So that's why you saw such a spike in the data. We were able to dedicate 2 people going around, not just observing, but also really seeing practices, seeing nuances to practice, helping those areas improve, being real-time, in the moment educators. They've really been such a value, and really from all that work, we landed an A grade with Leapfrog. So we're very proud of that work and proud of our hand hygiene team and the leadership that LaKita has exhibited with our program. Really, it's continued to really amplify. So I end with, if folks are interested on a nerdy level, we did publish the results of our program up there at the top. I'm happy to share that. If you're into more kind of public domain papers, we were in the Yahoo News, and I show this picture of Dr. Hickson and myself, not because we look really cool, because you always have to be humble when you try and improve practice. And if you look closely at the picture and look at the far left, you see a foam dispenser that is entirely empty. So we were on the front page of the Yahoo News talking about how great we do with hand washing and picked a room that didn't have a product. So you have to stay humble. You have to really always look for opportunities to improve with anything you do. And so I'm happy to have a time to talk about it. I think really hopefully share our experiences. I want to bring in LaKita. I know you're on here, LaKita. Come on screen, and I want if you want to kind of, LaKita, first espouse on anything that I've said or any kind of lessons learned from you and the team in the field as a lot of folks in this program are trying to work on improving basic practices. And it could be whether it's washing your hands or wearing a mask or other kind of conversations with folks. Just kind of give a couple of tidbits, and then I think we can open up for questions from the group.
You did a wonderful job, Dr. Talbot. I appreciate you just going in depth with the program, and I think you hit a lot of good areas. We do have 2 dedicated hand hygiene observers, and they have really opened my eyes to the different areas as they go and talk with the managers to see what their issues and problems are, which helps to understand what may be going on or the nuances that are happening in their area, and what trends that we can help with those areas. And I will call one area is like our trauma area. Our trauma area is an open bay area, and I think when the observers was going over there, they wasn't realizing that they had outside of their bay area, they had dispensers, and they was thinking that the individuals wasn't washing their hands. So it helped me to help the observers to make sure that they make note of the area. So that's been really, really helpful. Other things that I would say about the program in itself is we all here to help one another, and we all here to take care of the patient and make sure that the patient is safe, as well as our own coworkers, as well as ourselves, because we don't want anyone sick, and we want to make sure that we all in this together. So we try to come all together and remind them that it's not just one person. We're all in it. We all in together. And once we all in, then it's a bouncing effect for other individuals. And we do like to have like champions, as Dr. Talbot says, not just being an observer, but allowing other people to be a part, like a secret shopper. It may not count towards a pillar goal, but it helps that area itself, like, hey, this is what we need help with. We have physicians that may be not washing their hands during a particular time, and then that way, that's a different conversation in order to see who are the culprit in order to have a conversation with them as a group, not necessarily as an individual, in order just to help the team as well as everyone else. I'm proud of the program and how it's progressed. I'm not sure if you all have any questions. I'd be glad to answer any questions that you may have. I will say that we do have areas that have sensitivity to the product, and we have other products that can help with those issues as well. As long as they're being reported in the correct manner, we can address those issues, but it's hard to address issues if we don't know that there's a problem. So we do have something in place where we have, it's called occupational health for us, which is an inside employee medical center, I would say. And all of those requests goes there. And then on a yearly or maybe couple year basis, we look at it and just see who are those individuals are having problems, or what is the culprit issues with the sanitizer, in order to open up more product for the areas. And they're able to order that product in order to have that product in their area.
LaKita, can you give examples? So how would you're very experienced with this. How do you coach if you see someone coming out and forgetting to wash their hands, how do you coach someone to remind them in a professional way? And how do you tell them to handle if they were to get pushback?
I've normally when someone doesn't wash their hands, and I know without a shadow of a doubt that they didn't wash their hands, I'd be like, hey, don't forget to wash your hands. Or if I don't know and I'm kind of not really sure whether they wash their hands or not, I'll say, hey, I saw that you came out of the room. Did you forget to wash your hands? And if they tell you yes, that they wash their hands, I normally give it to them. But if they say no, we expect them to just say thank you, or thank you for the reminder, or because sometimes we forget. I mean, we all are human and things happen. I do see a comment that says, can you comment thoughts on traditional in-service learning versus the real-time education?
I think I'll take a little stab and LaKita, I think maybe can learn, but I think you know, the traditional in-service where you do kind of often it's kind of the online kind of webinar training. I think there's a little value with that. At least people have heard the expectation, but I don't think it can replace the value that we have, like with Trinita and Ashley, in real time. As people are busy doing their thing, people, especially when they come on board or they do that in-service training, it's not just the hand hygiene training, they're doing a lot of training. And so it's easy to forget things. And so if you can really do it in the moment with a really synthesis, and especially if it's a logistic challenge, like, oh my gosh, how am I have a trouble getting, you know, access, or what do I, you know, helping them with that and educating in real time, I think that probably sticks better, honestly. I don't know, LaKita, if you agree with that.
No, I do, because it changes behavior. It's just almost like going in and brushing your teeth. You know, when you wake up in the morning, you go probably straight to the sink to brush your teeth before you leave out the house. So we just want to create good behavior. So as soon as you hit that door, you know to just wash your hands. And even with coming out, and I mean, like I was saying before, people do forget, and we don't hold them accountable for. I mean, hold them. We don't say, oh, you forgot to wash your hands. We'll just be like, oh, okay, just remember to wash your hands, because we want to protect the patient and protect yourself. When we do have someone that may not give us good credo behavior and say, I wash my hands, we would just say, thank you. We appreciate you, because we don't want to go back and forth. That's not what we want to do. Like I said, we just want to create good behavior and just be able to remind them, because by you reminding them, and they may not be so polite when they come back, it reminds them to wash their hands the next time. Or they may see you again and say, oh, here's that lady, let me wash my hands. So I mean, we just really just trying to create good behavior. And I think it's kind of cute when I see them, they'll do this in front of me, and I'm like, good job, because we want to make sure that we know that's a good job, because we want to make sure that they getting the germs off their hands and not touching all surface of everywhere and spreading it to other places.
I think it too goes to, like, if you put yourselves in their shoes and you're busy and you forget, how would you want to be reminded, right? And I think that's the core of the practice. It's not, as LaKita said, it's not punitive. We all want to improve, and if there's someone in the group that like doesn't want to improve and doesn't believe in hand hygiene and doesn't want to prevent infections in folks, that's a larger conversation. But I think that's probably extremely rare. And I think it's just we get busy, and maybe we haven't put enough dispensers in places where they work, and we need to, those kind of things. So helping kind of that dialogue. Looks like there's a question, kind of more of a comment about kind of rewarding acknowledgement. And I think that's really important, because as I noted, we often tend to focus on where we have opportunities to improve, and we don't tend to acknowledge those that really, and hold them up kind of in a positive deviance kind of model of, gosh, this unit really gets it. They're doing some great things, and allow them to kind of highlight the wins and how they do that. We've had units do things like little awards each week, like the best hand washer of the week, or those kind of things, or just have a little fun with it, and really kind of get motivation and morale up with that as well.
We also give like little hand sanitizers. I don't know whether you're able to see it or not, but we pass these out. We pass these out as well. They like little sanitizers to stick around, wear around the neck. So we give them those, and we do have an area that is struggling with hand hygiene that gives out little candy, like pass out candy for good behavior, in order for them just to put in their pocket and eat it for later, just to let them know that, hey, we see what you're doing and we appreciate you protecting everyone. Oh, and for our observers, that have been completing the observations and putting the information in our database, we've given T-shirts. We passed out T-shirts letting them know, hey, we appreciate you becoming an observer and being an observer and getting those observations in every month. There is also a day for Hand Hygiene Day, which is July 5/5, May 5th. May 5th is World Hand Hygiene Day. So we do things for World Hand Hygiene Day just to remind them, hey, it's an important day as well. And reminder to to do hand hygiene each and every time.
That's excellent. Any other questions from the group? Or hopefully this is helpful as you're working on your improvement areas. But it's been, and this was a journey. This was not something that we were able to fix in 3 months. It really took a very long, measured, purposeful road to get where we are. And we still have to be very vigilant because, as we saw with things like COVID, people got, busier and tired and just forgot some of the basics. And we had to really reboot and make sure we kind of help them do the right things to protect themselves and their patients. I'm not seeing any more questions. Thank you, Carol. As always, if folks think of things afterwards, Isaac knows how to find us, and please send them our way.
Yeah, that was great. Thank you so much for speaking with us, Dr. Talbot and LaKita. That was really great. In follow-up, I will send a recording of this webinar out to everyone who received the calendar invite. So if any part you wanted to watch again or look at the slides or anything like that, that'll be available. It will also be on our website, which I can also send in that follow-up email. Really quickly before we end, I'm going to send another link in the chat. If you could please take the time to fill out the evaluation of this webinar for us. It's something that we do in order just to get feedback and to make sure that the presentations are being beneficial to everybody so that we're making use of everyone's time. So I'm going to send that out through right now. And if you could fill that, it'd be great. Other than that, if there's no other questions, we can end it now, and people can get to lunch or whatever else they got going on the rest of the day. So yeah, great.
Thanks, everybody.